I'm Dr. Michael Reynolds, an anesthesiologist with over 15 years of experience, currently practicing at Oakwood Surgical Center. Throughout my career, I've witnessed remarkable advancements in anesthesia techniques and patient safety protocols. Yet, no matter how many times I step into the operating room, each case retains a sense of gravity and unpredictability. Oakwood Surgical Center, known for its commitment to cutting-edge surgical procedures and comprehensive patient care, has been my professional home for the last 7 years. Our team prides itself on a multidisciplinary approach, integrating the latest technology with compassionate care, ensuring every patient receives the best possible outcome. From the outset, Oakwood has been a beacon of innovation. The surgical suites are equipped with the latest anesthesia machines, advanced monitoring systems, and digital integration that allows real-time data sharing across the surgical team. The center emphasizes patient safety and comfort, supported by protocols designed to minimize risks and enhance recovery. It is within this high-caliber environment that I encountered a case that would challenge my understanding of anesthesia and consciousness in ways I had never imagined. The case began like many others, a patient scheduled for a complex abdominal surgery requiring general anesthesia. However, what set it apart was what unfolded afterward. The patient's report of vivid awareness during the procedure, describing moments and details that should have been impossible to perceive while under deep sedation. As the anesthesiologist responsible for ensuring unconsciousness and pain control, this revelation struck me profoundly. In my years at Oakwood, I have been part of numerous surgical cases, ranging from straightforward procedures to intricate operations involving multiple specialties. The culture here is one of meticulous preparation and teamwork. Before every surgery, the anesthesiology team meticulously reviews the patient's medical history, current health status, and specific anesthesia plan. We tailor our approach to the individual, balancing efficacy with safety, and maintain continuous monitoring throughout to detect any variations in consciousness or physiological status. The operating rooms at Oakwood are designed to foster seamless collaboration among surgeons, anesthesiologists, nurses, and technicians. Each room is a symphony of technology and human expertise. Monitors track vital signs like heart rate, blood pressure, oxygen saturation, and, crucially, the depth of anesthesia through processed EEG readings. These systems are vital in ensuring the patient remains appropriately sedated, especially during prolonged and complex surgeries. As the lead anesthesiologist on the case in question, I was confident in our protocols and equipment. The patient, Mrs. Laura Bennett, was admitted for what we anticipated would be an intricate but routine abdominal procedure. Laura's preoperative assessments showed no unusual sensitivities or risk factors that would complicate anesthesia. Her medical history was unremarkable, and all pre-surgical labs and imaging suggested she was an excellent candidate for surgery under general anesthesia. The surgical team was assembled with specialists highly experienced in their respective fields. The atmosphere in the OR was professional yet calm, reflecting the collective confidence in the plan ahead. Everyone understood their role, and I took particular responsibility for maintaining Laura's unconscious state, pain relief, and physiological stability throughout the operation. Despite the high stakes, there was a sense of routine, the kind that comes from years of practice and trust in the systems designed to safeguard the patient. We had prepared an anesthesia regimen tailored to Laura's needs, incorporating intravenous agents and inhalational anesthetics, balanced carefully to ensure rapid induction and smooth maintenance of anesthesia. Our monitoring equipment was calibrated and working flawlessly, continuously feeding data to our anesthesia workstation. The day of the surgery was marked by an air of focused determination. The team carried out final checks, confirming airway equipment, intravenous access, and all monitors were in place and functioning. The anesthesia induction proceeded without complication. Laura's vital signs remained stable as she transitioned from awake to unconsciousness. Throughout the procedure, I maintained vigilant observation of her physiological responses and adjusted anesthetic dosages accordingly. The surgical team commenced the abdominal operation, navigating through the complexities that the procedure entailed. I continued to monitor Laura's status, confident that she was deeply anesthetized and unaware of the unfolding events. The technology at our disposal allowed for real-time assessment of her brain activity, heart rhythm, and respiratory parameters. All indicators suggested a state of appropriate anesthesia. However, the case took an unexpected turn after the surgery when Laura reported that she had been aware during the operation. She recalled specific details about the surgical environment, the voices of the team, and even the sensations of instruments that should have been imperceptible under general anesthesia. Initially, I found it difficult to reconcile her account with the objective data from the anesthesia monitors, which indicated no signs of consciousness or awareness. This revelation unsettled me deeply. It challenged my confidence in the monitoring systems and the very protocols we rely upon to ensure patient safety. The notion that a patient could experience such vivid intraoperative awareness, despite all precautions and technology, was both humbling and troubling. Oakwood Surgical Center, with its reputation for excellence, had to confront this anomaly head-on. In the immediate aftermath, I engaged in thorough discussions with the surgical and nursing teams, reviewing every aspect of the case. We examined anesthesia records, drug administration logs, and monitor data. We questioned whether any equipment malfunction or human error could have contributed to this phenomenon. Yet no clear cause emerged. I also reflected on my own role and experiences. Throughout my career, I had encountered rare instances of patients recalling fragments of surgery, but never with such clarity and coherence. The prevailing belief is that modern anesthesia techniques, combined with advanced monitoring, virtually eliminate the risk of intraoperative awareness. Laura's case forced me to confront the uncomfortable reality that our understanding of consciousness and the effects of anesthetics remain incomplete. The experience sparked a renewed sense of inquiry and determination within me. I realized that anesthesia, despite being a cornerstone of modern surgery, still holds mysteries that we must strive to unravel. Laura's report was not just a clinical anomaly. It was a call to deepen our knowledge, refine our techniques, and enhance patient safety. At Oakwood Surgical Center, this case became a catalyst for broader discussions among anesthesiologists and surgical staff. It highlighted the need to remain vigilant, question assumptions, and continuously seek improvements in how we assess and manage anesthesia depth. It also underscored the importance of listening carefully to patients' experiences, no matter how unexpected or unsettling they may be. As I reflect on that day and the events that followed, I am reminded that medicine is as much an art as a science. Technology and protocols provide invaluable guidance, but the human element, the patient's perspective, the clinician's judgment, and the collaborative spirit of the team remains central to care. Laura's case challenged me to balance confidence with humility and to embrace the unknown as an opportunity for growth. This case at Oakwood Surgical Center marked the beginning of a journey, one that would lead me to explore the limits of anesthesia, the nature of consciousness, and the profound connection between patient and provider. It reaffirmed my commitment to the principles of safety, empathy, and relentless pursuit of knowledge that define anesthesiology, and it set the stage for the complex story that was unfolding before us. The operating rooms at Oakwood Surgical Center are remarkable spaces, blending cutting-edge technology with a carefully orchestrated human rhythm. Walking into one of these suites, you're immediately struck by the precise choreography. Lights positioned to eliminate shadows, monitors glowing softly with vital information, and a team of specialists moving with practiced efficiency. Every element is designed to support the patient's safety and the surgical team's focus. This environment, where science and skill converge, was where I first met Mrs. Laura Bennett. Laura was admitted for a complex abdominal surgery that required meticulous care and coordination. From the moment she arrived, her case was handled with the utmost professionalism and empathy. The preoperative area was buzzing with activity, yet the atmosphere remained calm, underscoring the confidence and experience of the Oakwood team. Nurses checked her vitals while anesthesiology technicians prepared the necessary equipment. Laura, though understandably nervous, was reassured by our clear communication and attentive care. In preoperative assessments, Laura's medical background revealed no significant risk factors or allergies. She was a middle-aged woman with a history of mild hypertension, well controlled with medication, and no previous surgeries. Her physical exam and laboratory results were within normal limits. Radiological imaging confirmed the nature and extent of the abdominal condition requiring surgery. The plan was for a carefully executed procedure, designed to address the issue while minimizing trauma and recovery time. The surgical team was assembled with specialists experienced in abdominal operations, including a lead surgeon renowned for her precision and innovation. The nurses and technicians were equally skilled, each member acutely aware of their responsibilities and the importance of seamless teamwork. Within Oakwood's culture, this collaborative spirit is not just encouraged, it is expected. Every member of the team understands that patient outcomes depend on clear communication, vigilance, and mutual respect. Before surgery, Laura underwent a thorough briefing where we explained what to expect before, during, and after the procedure. I took the time to discuss the anesthesia plan with her in detail, addressing any concerns and ensuring informed consent. We talked about general anesthesia, the medications that would induce unconsciousness, and the monitoring techniques that keep patients safe. Laura's questions were thoughtful and showed a desire to understand the process. I appreciated her engagement. It's a crucial part of patient care that often goes underappreciated. The preoperative holding area was a place of transition, where anticipation mingled with clinical precision. Here, Laura was connected to monitors that recorded her heart rate, blood pressure, oxygen saturation, and respiratory status. The anesthesia team reviewed her chart one last time, confirming doses and equipment readiness. Intravenous lines were established for medication administration, and the anesthesia machine was calibrated for her specific needs. The surgical suite itself is a marvel of modern medicine. Beyond the sterile field and surgical instruments lies a complex array of technology designed to safeguard the patient at every moment. Anesthesia machines are equipped with multiple fail-safes, and the monitoring systems provide continuous feedback on physiological parameters. Advanced electroencephalogram, EEG, technology enables real-time assessment of brain activity, helping to gauge the depth of anesthesia more precisely than ever before. The dynamics of the surgical team during these moments are a blend of focus, anticipation, and quiet confidence. Surgeons prepare their instruments while nurses verify surgical counts and ensure all materials are sterile and at hand. Anesthesiologists and their assistants monitor the patient's status, discussing the anesthesia plan and potential contingencies. This is a moment where both technology and teamwork must operate flawlessly. Laura's case was no exception. As she was transferred to the operating table, the team coordinated smoothly, with clear verbal communication and practiced efficiency. The environment remained calm, underscoring the collective focus on patient safety and procedural success. The anesthesiology team prepared for induction, ready to administer the medications that would take Laura into unconsciousness safely. Throughout this process, the surgical center's emphasis on patient-centered care was evident. Oakwood is not just about technical excellence. It is about treating the whole person. The preoperative nurses provided warm reassurance, addressing Laura's anxieties with kindness and professionalism. The surgeons made themselves available to discuss the procedure and postoperative expectations. As the anesthesiologist, I took pride in being the bridge between Laura's waking experience and the surgical world she was about to enter. What stood out during this phase was the thoroughness and care with which every step was handled. The team's preparation extended beyond the technical. It encompassed an understanding of the psychological and emotional dimensions of surgery. We know that patients often feel vulnerable and uncertain, and part of our mission is to provide stability and trust through clear communication and empathetic care. In the moments before induction, I reviewed Laura's records once more, confirming her medication history, allergies, and vital signs. The anesthesia team conducted a final equipment check, ensuring all monitors and safety systems were functioning optimally. The surgical instruments were arranged neatly, ready for the procedure. The atmosphere, while professional and focused, was also suffused with a quiet sense of reassurance. This phase of patient care, preparation, and assessment is often overlooked by those outside the medical field, but it is critical to surgical success. Every detail, from the accuracy of laboratory results to the reliability of monitoring equipment, contributes to the safety net that protects the patient. At Oakwood, these details are scrutinized meticulously, reflecting a culture where excellence is the standard. Reflecting on my first encounter with Laura, I recall her as a composed and collaborative patient, eager to understand the process and participate actively in her care decisions. Her trust in the surgical team was palpable, and it was a privilege to be part of that experience. This trust would later be tested in ways we could not have anticipated, but in these early moments, it was an unspoken bond that underscored our shared goal of a successful surgery. As we moved toward the induction of anesthesia, the surgical team's synergy was evident. The surgeon reviewed the operative plan one last time, the nurses ensured all counts were correct, and the anesthesiology team prepared the medications. The operating room, with its quiet hum of machines and focused professionals, was a stage where science, skill, and human care converged. This intricate dance of preparation set the stage for the events that would follow, events that would challenge our understanding of anesthesia and consciousness. But at this moment, it was the calm before the storm, a testament to the dedication and expertise that defines Oakwood Surgical Center and the professionals who serve there. The moment we began preparing Laura Bennett for anesthesia induction was one of intense focus and precision. As the anesthesiologist responsible for her care, I was acutely aware that every detail mattered. Anesthesia is a delicate balance. Too little and the patient risks awareness or pain. Too much and we face the dangers of hemodynamic instability or prolonged recovery. Oakwood Surgical Center's protocols emphasize individualized anesthesia plans, tailored to each patient's physiology, medical history, and the specific demands of the surgery. For Laura's complex abdominal procedure, we devised a plan that combined intravenous induction agents with inhalational anesthetics to maintain unconsciousness and analgesia. Given her medical history and baseline vitals, this approach promised rapid onset, stable maintenance, and smooth emergence from anesthesia. The drugs selected included propofol for induction, known for its rapid onset and favorable recovery profile, supplemented by opioids for pain control and muscle relaxants to facilitate intubation and surgical access. The anesthesia induction began with the administration of intravenous medications through a well-established peripheral line. Laura's vital signs were displayed prominently on the monitors. Heart rate steady, blood pressure within expected range, oxygen saturation near 100%. The anesthesiology team monitored these parameters continuously, ready to respond to any fluctuations. The operating room was quiet except for the soft beeping of monitors and the occasional exchange of brief, focused communication among team members. As Laura drifted into unconsciousness, I ensured that the airway was secured with an endotracheal tube, a standard procedure for general anesthesia during major abdominal surgery. This step is critical to maintain ventilation and oxygenation, especially when muscle relaxants are used. The tube was placed under direct visualization, and its position confirmed by capnography and breath sounds. The team's experience made these maneuvers routine, but no less vital. Throughout induction and maintenance, we employed advanced monitoring protocols that go beyond basic vital signs. Oakwood Surgical Center utilizes processed electroencephalogram, EEG, monitoring to assess the depth of anesthesia. This technology provides real-time feedback on brain activity, helping us detect any signs of awareness or insufficient sedation. The EEG readings showed a pattern consistent with deep anesthesia, reassuring me that Laura was unconscious and not perceiving the surgical stimuli. The anesthetic agents were carefully titrated to maintain this state. We adjusted dosages based on dynamic feedback from the monitors, Laura's physiological responses, and the surgical stimuli encountered during the procedure. This approach requires constant vigilance and expertise. Anesthesia is not a static state but a dynamic interplay between pharmacology, physiology, and surgical demands. The surgical team proceeded with the abdominal operation, confident in the anesthesia management. Surgeons rely heavily on the anesthesiologist's ability to maintain an optimal balance, adequate anesthesia to prevent movement and awareness, yet stable enough to support vital organ function. The anesthesiology team also continuously adjusted medications to manage Laura's fluid balance, blood pressure, and pain control, all crucial to a successful surgery. Despite the complexity of the procedure, the operating room's atmosphere remained composed and professional. Monitors tracked every heartbeat, breath, and brainwave, while anesthetic delivery systems responded seamlessly to changes in concentration requirements. This high level of integration between technology and clinical judgment is what defines Oakwood's approach to patient care. I watched closely as the surgery progressed, noting the subtle physiological cues that guide anesthesia management. A slight increase in heart rate or blood pressure can indicate inadequate analgesia or light anesthesia, prompting adjustments in medication. Conversely, a sudden drop may signal excessive dosage or a physiological disturbance requiring intervention. These signals are often fleeting but critical, demanding continuous attention. Laura's vital signs remained stable throughout the induction and maintenance phases. The EEG monitor showed consistent patterns of unconsciousness, and there were no spontaneous movements or reflexes that would suggest inadequate anesthesia. The airway was secure, ventilation controlled, and oxygenation optimal. All parameters aligned with our expectations for a routine but carefully managed anesthesia course. The anesthesia team remained alert to potential complications. Anaphylaxis, aspiration, awareness, and hemodynamic instability are risks inherent to general anesthesia, and preparedness is key. Oakwood Surgical Center's protocols include rapid response measures and comprehensive training to handle these emergencies effectively. Our team drills regularly to ensure that, should an unexpected event arise, the response is immediate and coordinated. During the surgery, we also monitored Laura's temperature, electrolytes, and urine output, as these factors influence anesthesia metabolism and overall physiological stability. Maintaining normothermia and homeostasis reduces surgical stress and improves recovery outcomes. The anesthesiology team collaborated closely with nursing staff to manage these variables throughout the operation. As the procedure continued, I intermittently communicated with the surgical team, updating them on Laura's status and anticipating adjustments needed for anesthesia depth. This dialogue is essential. Surgical stimulation varies throughout the operation, requiring coordinated responses to maintain patient comfort and safety. The team's seamless communication exemplified the culture of collaboration at Oakwood. The induction and maintenance phases of anesthesia are, in many ways, the most critical periods for patient safety. Properly executed, they allow the surgical team to perform complex procedures without causing pain or distress. However, despite all precautions and monitoring, the phenomenon of anesthesia awareness, where a patient becomes conscious during surgery, remains a rare but serious concern. It was this very concern that would later cast a shadow over Laura's case. At this stage, before the unexpected revelations came to light, I felt confident in the anesthesia management. The technology, the protocols, and the team's expertise seemed to assure an uneventful experience for Laura. The induction was smooth, the maintenance stable, and the monitoring comprehensive. Yet, the human brain and consciousness are complex, and sometimes defy our best measures and understanding. Throughout the procedure, I kept a mental checklist of potential warning signs and contingency plans. We were prepared to deepen anesthesia or intervene if there were any indications of awareness or physiological distress. The team's readiness and Oakwood's resources provided a robust safety net. Still, the possibility that a patient might perceive aspects of the surgery despite these measures was a sobering thought. As the surgery advanced, I remained vigilant but reassured by the data. Laura's vital signs and EEG readings aligned with a deep anesthetic state. No spontaneous movements, no changes in autonomic responses suggested that she was anything but unconscious. The medications flowed through infusion pumps with precise control, adjusted minute by minute to the surgical demands. The operating room's environment, a fusion of technology and human expertise, carried on with its purposeful rhythm. Each member of the team played their part, confident in their roles and the systems supporting them. For me, as the anesthesiologist, this phase was both routine and critical, a balance of science, art, and responsibility. Little did I know, the confidence we shared in our anesthesia plan would soon be challenged by Laura's own account of her experience. A report that would shake my understanding of consciousness under general anesthesia and compel us to look deeper into the mysteries that still surround this vital aspect of surgical care. Midway through Laura Bennett's surgery, as I observed the anesthesia monitors, a subtle but unusual pattern caught my attention. The processed EEG readings, which until then had shown a stable, deep anesthetic state, began to fluctuate slightly, presenting transient bursts of increased brain activity. These spikes were brief and did not trigger any alarms, nor were they accompanied by changes in vital signs such as heart rate or blood pressure. At first, I attributed them to minor artifacts, perhaps a slight movement of electrodes or electrical interference common in operating rooms. The rest of the monitoring parameters remained within normal limits, and Laura exhibited no physical signs of awareness or distress. Despite the absence of overt indicators, something about these fluctuations lingered in my mind. The anesthesia team prides itself on vigilance and attention to detail, and even the faintest anomaly warrants scrutiny. Throughout the remainder of the surgery, I continued to monitor the EEG closely, noting that the irregularities persisted intermittently, but without clear correlation to surgical stimuli or physiological changes. I adjusted anesthetic delivery slightly as a precaution, increasing the depth marginally, and reassured myself that the monitoring technology was functioning properly. The surgical team continued their work seamlessly, unaware of my quiet concern. The surgeon's focus was on the intricacies of the abdominal procedure, navigating delicate tissues and ensuring meticulous reconstruction. Nurses and technicians maintained the sterile field and assisted with instrument exchanges, all while maintaining a professional calm. The operating room, a space of intense concentration and precision, carried on as designed. It was only after the surgery, during routine postoperative assessments, that the true significance of those subtle EEG fluctuations became clear. Laura, now awake and recovering in the post-anesthesia care unit, began to describe an experience that was both vivid and unsettling. She recounted moments during the surgery when she was acutely aware of her surroundings, despite the general anesthesia intended to render her unconscious. What struck me most was the detail in Laura's account. She described hearing voices, distinct conversations among the surgical team that she later confirmed were accurate. She could recall specific statements I had made while adjusting anesthetic levels, even noting my precise movements as I administered medications. Her descriptions extended to the sensations of touch and pressure in her abdomen, which she experienced without pain but with a clear awareness of the surgical activity. Initially, I found it difficult to reconcile Laura's recollections with the objective data from the monitoring equipment. The anesthesia records showed no evidence of inadequate drug delivery or technical malfunction. The monitors, including the EEG, suggested a state of unconsciousness throughout the procedure. Such intraoperative awareness under general anesthesia is considered rare, especially with modern monitoring and drug protocols, but it is a known phenomenon that can have profound psychological effects. Within the anesthesia team, skepticism surfaced naturally. Could Laura's memories be the result of dreams, hallucinations, or postoperative confusion? Were her descriptions influenced by anxiety or the residual effects of medications? To explore these possibilities, I engaged in detailed conversations with Laura, listening carefully and validating her experience without judgment. I also reviewed the anesthesia records again, cross-referencing times and events with her reported sensations. What was particularly compelling was the correlation between her reported awareness and the subtle EEG fluctuations I had observed during surgery. Although these bursts of increased brain activity were brief and not accompanied by physiological signs, they suggested moments when Laura's brain may have been more responsive than the monitors indicated. This raised questions about the reliability of current monitoring systems and the complex nature of consciousness under anesthesia. The surgical team, initially unaware of these nuances, joined in discussions to better understand the implications. The lead surgeon expressed surprise but empathy, recognizing the importance of addressing the patient's experience alongside the technical success of the operation. The nurses recalled no signs of distress or movement during the procedure, reinforcing how covert this awareness was. In the days following surgery, Laura's vivid memories became a focal point of concern. She described feelings of vulnerability and fear associated with being conscious yet unable to communicate or move during the operation. These psychological effects underscored the profound impact that intraoperative awareness can have on patients, beyond the physical trauma of surgery itself. From a professional standpoint, Laura's case forced me to confront the limitations of anesthetic monitoring and the unpredictability of human consciousness. Despite the best technology and protocols, there remains a margin of uncertainty that challenges our ability to guarantee complete unconsciousness. This realization instilled a sense of humility and urgency to explore better methods of detection and prevention. Our team undertook a thorough review of the anesthesia equipment and drug administration logs. All systems were found to be functioning correctly, and dosage calculations were within standard ranges. No lapses in protocol were identified. This left us grappling with the question of how a patient could have such clear intraoperative awareness despite everything appearing normal on the surface. I reflected deeply on the emotional impact this had on both Laura and the anesthesia team. The trust a patient places in us is sacred, and the possibility that this trust might have been compromised, even unintentionally, was distressing. For Laura, the psychological aftermath included anxiety and sleep disturbances, requiring supportive care beyond typical postoperative recovery. The experience also highlighted the need for open communication with patients regarding the rare risk of anesthesia awareness. At Oakwood Surgical Center, we began to consider how consent processes and patient education might be enhanced to prepare individuals for all possibilities, no matter how unlikely. This transparency, while challenging, is essential to maintaining trust and ensuring informed decision-making. In the operating room, the phenomenon of intraoperative awareness is a silent threat. Patients cannot signal distress, and the signs may be subtle or absent altogether. Our reliance on monitoring technology, while invaluable, is not infallible. Laura's case brought this truth into sharp focus, reminding me that vigilance and empathy must go hand in hand. As I continued to care for Laura during her recovery, our conversations often returned to her experience under anesthesia. I encouraged her to share openly, acknowledging the legitimacy of her feelings and the reality of her awareness. This patient-provider relationship, forged through honesty and compassion, became a cornerstone of her healing process. Within the anesthesia community at Oakwood, Laura's case sparked important discussions. We revisited our understanding of consciousness, anesthetic depth, and the limitations of current monitoring techniques. Expert consultations and literature reviews became part of our response, as we sought to learn from this unsettling but invaluable experience. Ultimately, Laura's intraoperative awareness challenged not only our clinical practices but also our perceptions of what anesthesia truly entails. It underscored the complexity of consciousness and the human brain's elusive nature. For me as an anesthesiologist, it was a professional and personal turning point, a reminder that medicine is an evolving field where even the most advanced technology cannot eliminate all uncertainties. Laura's courage in sharing her experience inspired me to advocate for enhanced protocols and research dedicated to preventing anesthesia awareness. It also reaffirmed the importance of listening deeply to patients, valuing their narratives as integral to their care. Her story became a catalyst for change within Oakwood Surgical Center and beyond, emphasizing that patient safety encompasses both physical and psychological dimensions. In the quiet moments following surgery, as I reviewed the monitors and reflected on the team's performance, I carried the weight of this case with me. It was a profound lesson in humility, vigilance, and the enduring mystery of the human mind under anesthesia, an experience that would shape my approach to anesthesia care for years to come. In the days following Laura Bennett's surgery, as the initial shock of her recounting intraoperative awareness settled in, I found myself grappling with a complex mix of emotions: professional concern, personal introspection, and a profound sense of responsibility. As her anesthesiologist, I had dedicated myself to ensuring her comfort and safety during surgery. Yet, here was a patient who had experienced something that no amount of technology or protocol seemed to prevent: vivid consciousness during a procedure meant to render her deeply unconscious. Laura's account of her experience was not just a clinical report. It was a human story of vulnerability, fear, and confusion. She described how, in the midst of the surgery, she felt trapped in a silent limbo, aware but unable to move or communicate, surrounded by voices and sensations she could not control. The psychological impact was evident in her subsequent anxiety, difficulty sleeping, and moments of distress when recalling those hours. This was not an isolated medical anomaly. It was a deeply personal trauma that demanded more than clinical explanation. As I reflected on Laura's experience, I recognized the emotional toll it took on both her and the anesthesia team. For myself and my colleagues, there was a mixture of disbelief, frustration, and a relentless desire to understand what had gone wrong. We pride ourselves on the precision and reliability of our practice, and yet this case challenged the very foundation of that confidence. It was a humbling reminder that medicine, despite its advances, can confront us with uncertainties and limitations. The anesthesiology team convened several meetings to discuss the implications of intraoperative awareness in Laura's case. We reviewed the anesthesia records meticulously, scrutinized the drug dosages, verified equipment function, and analyzed the monitoring data. Despite our exhaustive efforts, no clear technical failure or protocol breach emerged. The anesthesia machines were operating flawlessly, the medication doses were appropriate, and the EEG monitoring had indicated adequate depth of anesthesia throughout the procedure. This absence of a definitive cause deepened my professional unease. It became clear that intraoperative awareness is a multifaceted phenomenon, one influenced not only by pharmacology and technology, but also by individual patient variability and the enigmatic workings of consciousness itself. This realization compelled me to expand my perspective beyond the mechanical aspects of anesthesia to consider the broader neurological and psychological dimensions. Emotionally, supporting Laura through her recovery became an integral part of my role. Our conversations went beyond clinical check-ins. They were moments of genuine human connection. I listened as she described her fears and frustrations, validated her feelings, and reassured her that her experience was real and taken seriously. This patient-provider relationship, grounded in empathy and trust, was essential in helping her navigate the aftermath of anesthesia awareness. At the same time, I grappled with my own feelings of responsibility. Was there something I had missed? Could I have altered the course of events? These questions echoed in my mind, fueling a determination to prevent similar experiences for future patients. I sought guidance from colleagues and experts in anesthesia awareness, engaging in discussions that illuminated the complexities of detecting and preventing consciousness during surgery. The emotional impact of Laura's experience also resonated within the broader Oakwood Surgical Center team. Nurses and surgeons expressed their support and concern, recognizing the importance of addressing not only the physical but also the psychological well-being of patients. This collective empathy fostered a culture of openness and learning, encouraging us to confront uncomfortable truths and seek improvements. One of the most challenging aspects was reconciling the limitations of current monitoring technologies with the need for patient safety. While EEG and other modalities provide valuable insights, they are not infallible indicators of consciousness. Laura's case underscored this gap, highlighting the urgency for ongoing research and innovation in anesthesia monitoring. It became clear that vigilance must be paired with humility and a commitment to continual advancement. In reflecting on this experience, I also came to appreciate the importance of transparency and communication with patients. Prior to surgery, discussions about anesthesia risks often focus on physical complications, with little emphasis on rare but significant phenomena like intraoperative awareness. Laura's case prompted me to advocate for more comprehensive, informed consent processes, where patients are made aware of all potential outcomes, empowering them with knowledge and reducing uncertainty. The psychological sequelae of anesthesia awareness cannot be underestimated. Patients like Laura may develop post-traumatic stress disorder, depression, or anxiety related to their experience. Recognizing this, we integrated psychological support and counseling into the postoperative care pathway, ensuring that patients receive holistic care addressing both body and mind. This approach reflects a growing understanding that healing extends beyond the operating room. Throughout this journey, I was reminded of the profound responsibility we carry as anesthesiologists. We operate at the intersection of science and human experience, managing states of consciousness that are still not fully understood. Laura's case was a poignant example of this delicate balance, challenging me to deepen my knowledge and compassion alike. As weeks passed, Laura began to regain a sense of normalcy, supported by a multidisciplinary team attuned to her needs. Our conversations evolved from recounting the past to focusing on recovery and resilience. Her courage in sharing her story became a source of inspiration for the team, motivating us to improve patient care and safety protocols. For me personally, this case became a catalyst for professional growth. I engaged in further education on anesthesia awareness, participated in research initiatives, and contributed to developing improved monitoring guidelines within Oakwood Surgical Center. Laura's experience transformed from a troubling anomaly into a driving force for positive change. This ordeal also reinforced the human dimension of medicine, the necessity of empathy, active listening, and genuine connection. While technology and protocols are indispensable, they must be complemented by attentiveness to the patient's emotional and psychological state. Laura's journey highlighted that healing is a holistic process, requiring us to honor the patient's voice as much as clinical data. In the quiet moments of reflection, I often thought about the fragile boundary between consciousness and unconsciousness, the mysterious threshold that anesthesia seeks to cross. Laura's case had exposed the porousness of that boundary in ways I had not fully appreciated before. It was a reminder that despite our best efforts, the brain's complexities can elude even the most sophisticated interventions. This experience deepened my commitment to advancing the field of anesthesiology, not only through technical expertise, but through compassionate care and patient-centered approaches. Laura's story serves as a powerful testament to the resilience of patients and the imperative for clinicians to listen, learn, and adapt. Ultimately, the emotional and professional challenges posed by Laura's intraoperative awareness reshaped my approach to anesthesia. It underscored the limits of certainty in medicine and the importance of humility in the face of the unknown. Through this journey, I found renewed purpose, a dedication to pushing the boundaries of knowledge while honoring the humanity at the heart of every patient encounter. In the days and weeks following her surgery, Laura Bennett's detailed account of her intraoperative experience became a focal point of our ongoing care and investigation. She spoke with remarkable clarity about what she had perceived during the hours she was supposed to be unconscious. Her descriptions went beyond vague impressions or fragmented memories. They were precise and, in many instances, astonishingly accurate. Laura recounted hearing conversations between myself and members of the surgical team, even repeating specific phrases that we had spoken during the operation. She described the distinct tones of our voices, the cadence of our speech, and the exact moments when I adjusted anesthetic levels. These verbal recollections matched the surgical timeline and actions documented in the operative record, lending credibility to her narrative. Beyond auditory perceptions, Laura also described tactile sensations, pressure on her abdomen, the movement of instruments, and the subtle shifts as the surgeons worked. Importantly, she emphasized that these sensations were not accompanied by pain, but by a heightened awareness of her body being manipulated. This differentiation was crucial, as it underscored that her experience was one of consciousness without the protective barrier of analgesia, a state that can be deeply disturbing. Initially, I struggled to fully comprehend how Laura could have such detailed awareness under deep general anesthesia. Yet, her precise descriptions compelled me to take her account seriously and delve deeper into understanding the phenomenon of anesthesia awareness. It became clear that this was not merely a rare clinical event but a profound psychological experience with lasting effects. In our postoperative discussions, Laura expressed feelings of confusion and isolation. She found it difficult to reconcile her memory of the surgery with what she had been told about being unconscious. Her trust in the medical team was shaken, and she grappled with anxiety about future medical procedures. Recognizing these psychological impacts, I referred her to specialized counseling services experienced in addressing trauma related to medical events. The psychological effects of anesthesia awareness are often underappreciated in clinical practice. Patients may experience nightmares, flashbacks, insomnia, and symptoms akin to post-traumatic stress disorder. Laura's case highlighted the necessity of holistic care that addresses both the physical and emotional aftermath of surgery. This realization prompted the integration of mental health support into our postoperative protocols at Oakwood Surgical Center. During our conversations, Laura emphasized the importance of being heard and understood. Her willingness to share her experience candidly fostered a therapeutic alliance that was foundational to her recovery. I made it a priority to maintain open communication, providing reassurance, answering questions, and validating her feelings. This approach contrasted with the traditional focus on physiological outcomes alone, reminding me that patient care extends far beyond the operating room. Laura's detailed account also spurred a broader inquiry within our anesthesiology team. We revisited the literature on anesthesia awareness, exploring the neurological underpinnings and risk factors associated with this phenomenon. Studies suggest that certain patients may have increased susceptibility due to genetic, pharmacological, or physiological variables. Understanding these factors is critical to improving prevention strategies. Our team also examined the limitations of current monitoring technologies. While processed EEG and bispectral index monitors provide valuable data, they do not offer absolute guarantees against awareness. Laura's experience underscored the need for advancements in brain monitoring that can more accurately detect consciousness during anesthesia. This became a priority in our ongoing quality improvement initiatives. In parallel, Laura participated actively in educating our team about the patient perspective on anesthesia awareness. Her first-hand insights enriched our understanding of the emotional landscape surrounding this rare complication. She advocated for enhanced patient education before surgery, emphasizing the need for transparent discussions about all potential risks, no matter how uncommon. This emphasis on informed consent and patient empowerment has since been incorporated into Oakwood's preoperative counseling protocols. Patients are now provided with comprehensive information about anesthesia, including the rare possibility of intraoperative awareness, and encouraged to voice any concerns. This transparency fosters trust and prepares patients psychologically for their surgical journey. Laura's experience also illuminated the importance of postoperative follow-up focused on psychological well-being. We established structured assessments to identify patients who may have experienced awareness or other distressing anesthetic events. Early intervention with counseling and support services has proven beneficial in mitigating long-term psychological sequelae. As I engaged with Laura's story, I was reminded that anesthesia is not merely a pharmacological state, but a complex interaction involving consciousness, perception, and memory. The human brain's response to anesthetic agents is intricate and individualized, resisting simple quantification. Laura's vivid recollections challenged us to rethink our assumptions and to approach anesthesia care with humility and curiosity. Her narrative reinforced the value of patient-centered care. Listening attentively to patients' experiences, acknowledging their fears, and addressing their concerns are essential components of healing. Laura's courage in sharing her story transformed a clinical anomaly into a catalyst for empathy and improvement within our practice. Moreover, Laura's case highlighted the necessity for interdisciplinary collaboration. Anesthesia awareness bridges neurology, psychology, anesthesiology, and surgery. Addressing it effectively requires a team approach that integrates medical management with psychological support. At Oakwood, we have since strengthened these collaborative efforts to provide comprehensive care. Throughout this process, I was struck by the resilience Laura demonstrated. Despite the distressing nature of her experience, she remained engaged and hopeful. Her journey inspired me and the team to strive for excellence in both the science and humanity of anesthesia care. In reflecting on Laura's detailed intraoperative awareness, I understood that our quest to eliminate such experiences must continue. It demands ongoing research, technological innovation, and a steadfast commitment to patient safety and dignity. Laura's story serves as a poignant reminder that behind every monitor reading and drug dose is a human being whose perception and well-being are paramount. As we move forward, Laura's contributions to our understanding of anesthesia awareness will remain invaluable. Her willingness to share her experience has helped shape more compassionate, informed, and vigilant anesthesia practices at Oakwood Surgical Center. It is a testament to the power of patient narratives in advancing medical care and fostering healing beyond the physical. Following Laura Bennett's vivid account of intraoperative awareness, our team at Oakwood Surgical Center embarked on a comprehensive investigation to identify possible causes and contributing factors. The goal was to understand how, despite adherence to protocols and the use of advanced monitoring, a patient could retain such clear consciousness during general anesthesia. This inquiry involved meticulous review of clinical records, equipment functionality, pharmacological considerations, and patient-specific factors. The first step involved an exhaustive audit of the anesthesia records from Laura's surgery. We scrutinized every detail, the timing and dosage of administered medications, the sequence of drug delivery, and the calibration of anesthesia machines. Our pharmacy and anesthesiology teams collaborated to verify that all drugs were within their potency and expiration dates. The records demonstrated that propofol, opioids, and muscle relaxants were administered within standard therapeutic ranges, consistent with best practices for a complex abdominal procedure. Next, the functionality of monitoring equipment was evaluated. The processed electroencephalogram (EEG) monitor, which provides real-time data on brain activity and anesthetic depth, was inspected by biomedical engineers. Calibration logs showed proper maintenance and no malfunctions during the surgery. The anesthesia workstation's delivery systems were tested for accuracy, confirming that the intended concentrations of anesthetic gases and intravenous agents were administered. No technical faults or interruptions were detected. We also reviewed the recorded vital signs throughout the operation. Laura's heart rate, blood pressure, oxygen saturation, and respiratory parameters remained stable and within expected ranges for general anesthesia. Importantly, there were no abrupt changes or trends suggestive of inadequate anesthesia or physiological distress. These findings reinforced the paradox of her intraoperative awareness occurring despite seemingly appropriate anesthetic depth and patient stability. Recognizing that equipment and drug administration appeared uncompromised, our attention shifted to patient-specific factors. We considered whether Laura's unique physiology or genetic makeup could have influenced her response to anesthetic agents. Pharmacogenomics, the study of how genes affect drug metabolism, has revealed that some individuals metabolize anesthetics differently, potentially leading to variations in drug efficacy and duration. Laura underwent genetic testing focused on polymorphisms affecting cytochrome P450 enzymes and other pathways involved in anesthetic metabolism. While preliminary, these results indicated no significant anomalies that would explain a rapid clearance or resistance to standard anesthetic doses. Nonetheless, this highlighted the complexity of individual variability and the current limitations in predicting anesthetic responses based on genetics alone. Another consideration was the possibility of psychological or neurological factors influencing anesthesia depth. Conditions such as anxiety or pre-existing neurological disorders can modulate brain activity and alter anesthetic requirements. Laura's medical history and preoperative assessments revealed no such conditions, but subtle factors may evade detection. This underscored the need for a nuanced understanding of consciousness and its modulation under anesthesia. To gain further insight, we consulted with experts in anesthesia awareness and neurophysiology. These specialists emphasized that the phenomenon is multifactorial, involving not only pharmacological factors but also the intricate dynamics of neural networks and consciousness. They highlighted that current monitoring technologies, while advanced, rely on indirect measures of brain activity and may not fully capture the patient's subjective experience. The consultations also examined the limitations of EEG-based monitors. These devices interpret electrical signals to infer anesthetic depth but can be influenced by artifacts, electrode placement, and individual brain variability. In some cases, patients may exhibit preserved awareness despite EEG patterns suggestive of unconsciousness. This gap in detection capability remains a challenge in anesthetic practice. Given these insights, we considered whether additional or alternative monitoring modalities could enhance detection of intraoperative awareness. Functional magnetic resonance imaging, fMRI, and positron emission tomography, PET, scans provide detailed brain activity mapping but are impractical in the operating room. Emerging technologies such as near-infrared spectroscopy, NIRS, and advanced EEG algorithms hold promise but require further validation. We also reviewed the anesthesia protocol employed during Laura's surgery. The regimen was consistent with established guidelines, balancing intravenous induction agents and inhalational anesthetics to maintain unconsciousness and analgesia. Dosages were titrated in response to physiological parameters and EEG feedback. No deviations from protocol occurred, reinforcing that even standard approaches may not guarantee awareness prevention in all patients. Recognizing the challenges in fully accounting for Laura's experience, we expanded our inquiry to include a review of literature and case reports on anesthesia awareness. Studies indicate that incidences, though rare, continue to occur despite technological advances. Factors such as emergency surgeries, previous awareness episodes, and certain patient populations carry higher risk. However, Laura did not fit these typical risk profiles, further deepening the mystery. This comprehensive investigation highlighted the inherent complexity of anesthesia awareness and the current gaps in our understanding. It became clear that while technology and protocols reduce risk, they cannot eliminate it entirely. Patient-specific factors, neural dynamics, and monitoring limitations contribute to a residual vulnerability. In response, Oakwood Surgical Center initiated a multidisciplinary task force to develop strategies aimed at minimizing intraoperative awareness. This group included anesthesiologists, neurologists, biomedical engineers, pharmacologists, and psychologists. Their mission was to integrate clinical findings with emerging research to enhance detection, prevention, and patient support. One initiative involved refining monitoring protocols by combining multiple modalities to improve sensitivity. For example, pairing EEG with hemodynamic monitoring and clinical assessment could provide a more comprehensive picture of anesthetic depth. The task force also advocated for increased training and awareness among anesthesia providers regarding subtle signs of consciousness. Pharmacological strategies were reviewed as well. Tailoring anesthetic regimens based on individual patient characteristics, including genetic profiles and psychological factors, may offer improved outcomes. Research into novel agents with more predictable pharmacodynamics and pharmacokinetics was encouraged. Patient education emerged as a key component, informing patients about the rare possibility of intraoperative awareness, while reassuring them of the measures in place to prevent it, fosters transparency and trust. Oakwood revised its informed consent process to include discussions about anesthesia awareness and psychological support options. The psychological dimension of anesthesia awareness also received attention. Integrating mental health professionals into perioperative care ensures that affected patients receive timely counseling and support. This holistic approach addresses both the physical and emotional consequences of such experiences. Throughout this process, Laura remained engaged and supportive. Her collaboration provided invaluable patient insight, ensuring that our initiatives remained grounded in real-world impact. Her experience became a catalyst for ongoing quality improvement and research at Oakwood. This journey underscored the multifaceted nature of anesthesia awareness and the necessity of a comprehensive, patient-centered approach. Despite advances, the phenomenon remains an area of uncertainty, demanding vigilance, innovation, and empathy from clinicians. As we continue to refine our understanding and practices, Laura's case serves as a reminder of the delicate balance between science and the human experience in medicine. It challenges us to push the boundaries of knowledge while honoring the individuality of each patient entrusted to our care. Laura Bennett's case ignited important discussions within Oakwood Surgical Center and the broader anesthesiology community. The realization that intraoperative awareness can occur despite our best efforts prompted a collective reflection on current practices, patient safety protocols, and the ethical imperative to improve detection and prevention strategies. It was clear that the phenomenon, though rare, demanded heightened vigilance and a concerted response. Within Oakwood, the anesthesia department convened several forums to share Laura's experience and examine its implications. These sessions fostered a culture of openness and learning, where clinicians could candidly discuss the limits of existing monitoring technologies and the challenges inherent in assessing consciousness under anesthesia. The case became a touchstone for education, encouraging anesthesiologists, nurses, and surgical teams to reevaluate their approaches. One of the key outcomes was a renewed emphasis on the importance of comprehensive patient monitoring. While advanced EEG-based systems provide valuable insights, the team recognized that no single modality is infallible. This understanding led to the development of multimodal monitoring protocols, integrating physiological parameters such as heart rate variability, blood pressure trends, and respiratory patterns alongside brain activity measures. The goal was to create a more robust safety net capable of detecting subtle signs of awareness. Dr. Reynolds, deeply affected by Laura's experience, emerged as an advocate for increased awareness of anesthesia awareness within the professional community. He began participating in regional and national conferences, sharing insights from the case and advocating for research into improved monitoring technologies. His presentations emphasized the need for a balanced approach that combines technological advancement with clinical acumen and patient-centered care. The discussions also highlighted the critical role of informed consent. Historically, preoperative counseling has focused primarily on tangible risks such as bleeding, infection, and anesthetic complications like allergic reactions. The possibility of awareness during surgery has often been overlooked or minimized. Oakwood Surgical Center responded by revising its consent protocols to include explicit discussions about this rare but serious risk. Patients are now educated about anesthesia awareness, its symptoms, and the support available should it occur. This transparency fosters trust and empowers patients to make informed decisions. Beyond the operating room, Laura's case spurred initiatives aimed at psychological support for patients who experience anesthesia awareness. Recognizing the profound emotional impact, Oakwood integrated mental health professionals into the perioperative care team. Psychologists and counselors became available to provide early intervention, helping patients process their experiences and mitigate long-term psychological consequences, such as post-traumatic stress disorder. The center also developed educational materials tailored to patients, explaining anesthesia processes in accessible language and addressing common concerns. These resources emphasize that while anesthesia techniques are highly effective and safe, rare events can occur, and the care team is committed to supporting patients through every stage. Laura herself contributed to the creation of these materials, offering a patient's perspective that enriched their authenticity and relevance. Within the anesthesiology community, Laura's case contributed to a growing dialogue about the need for ongoing research and innovation. Efforts to refine brain monitoring technologies are underway, exploring more sensitive and specific measures of consciousness. Emerging fields such as neuroinformatics and machine learning offer promising avenues for interpreting complex neural data in real time. Oakwood Surgical Center has committed to participating in collaborative research initiatives aimed at advancing these technologies. Training and continuing education for anesthesia providers have also been enhanced. Oakwood introduced simulation scenarios focusing on anesthesia awareness, enabling clinicians to practice recognizing subtle signs and responding effectively. These exercises foster critical thinking and reinforce the importance of vigilance, communication, and patient-centered decision-making. The interdisciplinary nature of addressing anesthesia awareness became increasingly apparent. Collaboration between anesthesiologists, neurologists, psychologists, and biomedical engineers is essential to develop comprehensive strategies that encompass prevention, detection, and patient support. Oakwood Surgical Center established a dedicated task force to coordinate these efforts, ensuring that initiatives are integrated and patient outcomes remain central. Laura's case also influenced policy discussions at professional organizations and regulatory bodies. The need for standardized reporting of anesthesia awareness incidents and consensus on monitoring guidelines gained prominence. Such measures facilitate data collection, trend analysis, and dissemination of best practices, ultimately enhancing patient safety on a broader scale. Throughout these developments, the human dimension of anesthesia care remained paramount. Laura's experience underscored that beyond algorithms and monitors, the patient's voice and psychological well-being are critical components of quality care. Oakwood's commitment to empathy, transparency, and patient engagement now informs every aspect of anesthesia practice. As Dr. Reynolds reflected on the trajectory following Laura's surgery, he recognized that her case had transformed from a clinical anomaly into a catalyst for systemic improvement. It had reinvigorated a culture of inquiry and compassion, reminding the anesthesia community that vigilance must be continuous and adaptive. The lessons learned extended beyond Oakwood, resonating with practitioners worldwide. Laura's story became a powerful testament to the importance of acknowledging uncertainty in medicine, embracing patient narratives, and striving relentlessly to enhance safety and trust. In this evolving landscape, Oakwood Surgical Center continues to prioritize patient safety through innovation, education, and empathy. Laura's experience remains a guiding force, inspiring ongoing efforts to reduce the incidence of anesthesia awareness and support those affected. The journey sparked by this case highlights the dynamic nature of medical practice, a constant interplay between technology, human factors, and the pursuit of understanding. It is a reminder that every patient encounter offers an opportunity to learn, improve, and reaffirm the commitment to care that lies at the heart of medicine. Supporting Laura Bennett through her postoperative recovery extended far beyond the physical healing of her abdominal surgery. The psychological scars left by her intraoperative awareness required a compassionate and comprehensive approach. At Oakwood Surgical Center, we recognized that addressing the human side of her experience was as vital as refining anesthetic techniques and monitoring protocols. Laura's support system became a cornerstone of her healing journey. Family members rallied around her, providing emotional comfort and practical assistance. Their involvement underscored the importance of a nurturing environment in recovering from both surgical trauma and the psychological distress associated with anesthesia awareness. We encouraged her loved ones to engage with the counseling services offered, fostering a shared understanding of the challenges she faced. Psychological recovery was facilitated through a multidisciplinary approach. Mental health professionals specializing in trauma and perioperative care worked closely with Laura to help her process the vivid memories of being conscious during surgery. Cognitive behavioral therapy and stress management techniques were employed to alleviate anxiety, nightmares, and the intrusive recollections that had disrupted her sleep and daily functioning. In addition to individualized therapy, Laura participated in support groups composed of patients who had experienced similar episodes of anesthesia awareness. These groups provided a safe space for sharing experiences, normalizing feelings, and building resilience. The sense of community and validation proved invaluable, transforming isolation into empowerment. Recognizing the profound impact of her experience, Laura became an advocate for patient-centered care within Oakwood. She collaborated with the anesthesia team to develop educational workshops aimed at raising awareness about anesthesia awareness among both healthcare providers and patients. Her insights enriched these programs, emphasizing the emotional and psychological dimensions often overlooked in clinical settings. This partnership between patient and provider fostered a lasting bond founded on trust, respect, and shared purpose. Laura's willingness to transform her ordeal into a catalyst for change inspired the entire team. It reminded me, as her anesthesiologist, that healing is a dynamic process requiring humility and openness to learning from those we serve. Within the clinical team, Laura's case prompted the development of patient-centered anesthesia protocols. These included enhanced preoperative counseling that addressed emotional preparedness, individualized anesthesia plans incorporating patient history and preferences, and structured postoperative follow-up focused on psychological well-being. The integration of these elements marked a shift towards holistic care. Oakwood Surgical Center also invested in training programs to sensitize staff to the psychological aftermath of anesthesia awareness. Nurses, surgeons, and anesthesiologists received education on recognizing signs of distress, communicating empathetically, and facilitating referrals to mental health services. This comprehensive approach aimed to ensure that every patient's experience was acknowledged and addressed. The lasting bond formed between Laura and the anesthesia team extended beyond clinical interactions. Regular check-ins and open lines of communication allowed her to share ongoing concerns and feedback. This continuity of care reinforced her sense of security and partnership, vital components in her recovery. Laura's involvement in peer education and advocacy extended to community outreach efforts. She participated in seminars and public forums, sharing her story to demystify anesthesia and encourage patients to voice their concerns. Her narrative helped break down barriers of fear and stigma, empowering others facing surgery to engage actively in their care. This human-centered focus enriched the culture at Oakwood, emphasizing that medicine is not merely the application of technology, but a relational practice grounded in empathy. Laura's journey highlighted the transformative potential of patient engagement and collaboration in advancing quality care. As her primary anesthesiologist, I witnessed firsthand the resilience and courage required to navigate such a challenging experience. Laura's recovery journey reinforced my commitment to integrating psychological support into perioperative care and to fostering environments where patients feel heard and valued. Moreover, the case underscored the importance of ongoing support systems beyond hospital discharge. Coordinating with primary care providers, mental health specialists, and community resources ensured that Laura's recovery was sustained and comprehensive. This continuity is essential in addressing the multifaceted nature of anesthesia awareness. The partnership between Laura and the Oakwood team exemplifies the profound impact of patient-centered approaches. Her story serves as a testament to the healing power of empathy, collaboration, and respect for the whole person. It reminds us that medical care must encompass not only physical interventions but also emotional and psychological nurturing. Reflecting on this journey, I am reminded that every patient's experience is unique and that care must be tailored accordingly. Laura's case has become a catalyst for systemic change within Oakwood, inspiring policies and practices that prioritize holistic recovery. The lessons learned extend beyond anesthesia awareness, informing broader approaches to surgical care and patient safety. They emphasize the necessity of treating patients as partners and recognizing the inseparability of mind and body in healing. Ultimately, Laura's recovery and advocacy illustrate the enduring human spirit's capacity to transform adversity into growth. Her collaboration with the medical team fostered innovations in care that continue to benefit patients today. This experience has deepened my understanding of the anesthesiologist's role, not only as a guardian of unconsciousness, but as a compassionate partner in the patient's entire surgical journey. It is a role that demands technical skill, emotional intelligence, and unwavering commitment to patient well-being. Laura's story, marked by challenge, resilience, and transformation, remains a powerful reminder of why empathy and patient-centered care must be at the heart of medicine. It is through such partnerships that we can hope to navigate the uncertainties of medical science while honoring the dignity and humanity of those we serve. Over time, Laura Bennett's recovery progressed steadily, both physically and emotionally. Her abdominal surgery had been successfully completed, and with the comprehensive support system we established at Oakwood Surgical Center, she gradually regained confidence and a sense of normalcy. More than just a patient, Laura became an active participant in the ongoing conversation about anesthesia awareness, transforming her personal ordeal into a mission to educate and advocate for others. Laura's involvement in educational efforts extended beyond our institution. She spoke at regional conferences, patient safety forums, and community health seminars, candidly sharing her experience with anesthesia awareness. Her narrative resonated deeply with audiences, bridging the gap between clinical data and lived experience. By giving voice to a phenomenon often relegated to the shadows, Laura empowered patients and clinicians alike to confront this rare but impactful complication openly. At Oakwood, her contributions sparked meaningful change. Educational materials developed with her input now form part of the standard preoperative counseling regimen. Patients are informed about the full spectrum of anesthesia risks, including the possibility of intraoperative awareness, with emphasis on available support and transparent communication. This approach has enhanced patient trust and engagement, fostering a culture of openness. Dr. Reynolds, profoundly influenced by Laura's journey, dedicated himself to advancing anesthesia safety through research, education, and advocacy. He spearheaded initiatives to integrate multimodal monitoring protocols and supported studies exploring novel technologies for detecting consciousness under anesthesia. His presentations at professional gatherings emphasized the importance of balancing technological innovation with empathetic patient care. Within Oakwood Surgical Center, interdisciplinary collaboration flourished. Anesthesiologists, surgeons, psychologists, and biomedical engineers worked closely to refine protocols, improve monitoring, and enhance postoperative support. This holistic approach reflected a commitment to addressing not only the physical but also the psychological dimensions of anesthesia experiences. Laura's story underscored the essential role of patient narratives in shaping medical practice. Her courage in sharing her experience challenged clinicians to listen more intently and to recognize the profound impact of anesthesia awareness beyond physiological parameters. It reminded us that medicine is a human endeavor, reliant on trust, communication, and compassion. As Laura continued to heal, she remained an integral part of the Oakwood community. Regular follow-ups ensured that her physical recovery was complete and that any lingering psychological effects were addressed. Her feedback informed continuous quality improvement efforts, ensuring that lessons learned from her case translated into safer care for all patients. The journey from a harrowing intraoperative experience to recovery and advocacy exemplifies the resilience of the human spirit, and the transformative potential of patient-centered care. Laura's participation in educating others has helped reduce stigma and fear surrounding anesthesia awareness, promoting proactive dialogue and preparedness. For Dr. Reynolds and the Oakwood team, this experience reaffirmed the importance of humility in medicine. Despite advanced technology and protocols, uncertainty remains, and the patient's voice is paramount. The case inspired a culture of continuous inquiry, where questions are welcomed and understanding deepened. Laura's story stands as a testament to the enduring partnership between patients and healthcare providers, a relationship built on trust, respect, and shared commitment to healing. It highlights that safety and compassion are intertwined goals, each enriching the other. In the broader context of anesthesiology, her case has contributed to a growing movement emphasizing patient engagement, transparency, and interdisciplinary care. It challenges the field to pursue innovations that prioritize not only physiological metrics but also the subjective experience of consciousness and well-being. As I reflect on this journey, I am reminded that every patient encounter offers an opportunity to learn, grow, and improve. Laura's experience has been a powerful catalyst for change, inspiring us to embrace complexity, uncertainty, and the profound humanity at the heart of medicine. Her heartbeat, once a source of mystery and concern, now symbolizes hope and progress. A reminder that even in the shadows of the unknown, light can emerge through empathy, collaboration, and relentless pursuit of understanding. In honoring Laura's story, we recommit ourselves to the highest standards of care, the continuous advancement of our field, and the unwavering dedication to the patients we serve. It is through this commitment that we can hope to navigate the challenges of medicine with courage, compassion, and integrity.